Hey everybody, it's Michelle Andrews. I'm glad to have you back. I have a good handful of you now that are following my videos. I so appreciate that. I hope you're learning everything you need to know regarding PALS and possibly the adult cardiac life support, huh? So I'm going to ask a favor. Will you go ahead and subscribe to my channel? It helps so much. And also comment to me. Good or bad, it doesn't matter. I'm always looking to improve. I know I've made some mistakes with some of these videos. I might have said the wrong word or the wrong amount. I'm going to make a video just kind of going through some corrections or maybe clarifying some things that I didn't clarify. So that'll be upcoming. Today, as promised, we're going over the T's. Remember, the last two videos are our H's, and today we're going over our T's. What are these H's and T's? They're the mnemonics that American Heart Association gave to us to help us consider what is causing some abnormal heart rhythms or causing someone to come in cardiac arrest or possible pending cardiac arrest, right? And so today we're going over our T's. If you purchased the PALS package, you have this PDF in front of you, okay? This is down the road. We'll see right here. I went ahead and bullet pointed the T's for you, okay? So we're doing T's today. The first one is tension pneumothorax, all right? So tension pneumothorax is really when air is allowed to enter the pleural space and it's prevented from escaping. As the interthoracic pressure starts to increase, it decreases cardiac output. That just makes sense. So what are the population of patients that are at risk for our tension pneumothorax? I'm going to tell you that it just makes sense to me that it would be pneumonia, trauma, asthma, cystic fibrosis, and definitely excessive positive pressure mechanical ventilation. So we want to be careful, when we're ventilating them. Your EKG complexes, the QRS complexes, are going to be very narrow, and the heart rate will ultimately be slow. Let's do our assessment, our primary assessment. That's the A, B, C, D, and E. In that, we'll see tracheal deviation to the contralateral side in A, airway. In B, we're going to see an increased work of breathing. They're going to have an increased respiratory rate, and it could lead to respiratory distress or possibly failure. Remember, they're trying hard to compensate. C stands for circulation. What are we going to see there? I wanted to go back on breathing. This is very important for tension pneumothorax. When you auscultate their lungs, what do you think you're going to hear on the affected side? Diminished to absent breath sounds. And if that's what you said, you're absolutely right. And that's kind of how you know. The tracheal deviation and then auscultating that affected side, it's a given. So circulation, what are you going to see? Neck vein distension or JVD, rapid and severe hypotension, tachycardia rapidly degrading to bradycardia. Because remember, they're trying to compensate, but eventually they're going to end up in bradycardia, and it happen rather quickly because This is very serious. You've got a change in the intrathoracic pressure of the pleural cavity, and it's putting pressure on the heart that's just trying to beat, and now it's just really struggling to beat, right? So we want to fix this quickly. What's their level of consciousness? It's going to be decreased. And exposure, the head to toe assessment, right? Their extremities will be pale and cool. And I just want you to know that all of this can lead to PEA. You know, and if you're thinking this could be an obstructive shock issue, you're absolutely right. They are in obstructive shock. The blood flow to the tissues and the organs is compromised. That's your tension pneumothorax. Your next one is cardiac tamponade. Cardiac tamponade is the accumulation of fluid or blood in the pericardial sac. So now we're talking about around the heart. There's, you know, a sac. In that little space in between is called the pericardium, and it can fill up with blood or fluid. Again, putting a lot of pressure on the heart, decreasing, you know, the effectiveness of the heart pumping, right? And can lead to cardiac arrest quickly. So your EKG is going to show rapid heart rate and narrow QRS complexes. All right, let's do our assessment, our A, B, C, and D, E assessment. That's our primary assessment. So airway is going to be compromised because they have a decreased level of consciousness. Remember the anatomy of the baby? So we're going to want to assist them with a patent airway and ventilation for sure. B stands for breathing. They're going to have an increased work of breathing. They're going to try. They're going to have an increased respiratory rate, and then they might lead to respiratory distress. Circulation, they're going to be tachycardic. They're going to have decreased peripheral pulses. This all makes sense if you think about the compression of the heart, right? And the blood not being able to flow as it wants to. So decreased peripheral pulses makes sense. JVD makes sense. Poor capillary refill for sure. And then here's what really makes sense. If you auscultate the heart, we're going to hear muffled heart sounds, aren't we? Yes, we will. And then D stands for disability. That's going to be a decreased level of consciousness. And E stands for exposure. Again, guys, they're going to have cool and pale extremities. Okay, so how are we going to fix it? A pericardial centesis, right? We need to aspirate the fluid or blood out of that pericardial sac quickly, right? So that the heart can quit struggling to beat and it can just relax and beat again and blood flow like it should again. That's another one, obstructive shock. If you're thinking that, you're right. The next T is going to be pulmonary thrombosis. Pulmonary thrombosis occurs when the pulmonary artery or its branches becomes partially or totally occluded. All right? It's not just blood clots. It can be fat. It can be air. Found that interesting, but that's the case. Who's at risk for a pulmonary thrombosis? Well, if a pediatric patient just had a central venous catheter inserted, they're at risk. But you know who I'm thinking of? Sickle cell patients, for sure, and coagulation disorder patients, right? Let's do our primary assessment on pulmonary thrombosis. Airway is going to be compromised again because their level of consciousness is decreased. So remember, patent airway, support ventilation, the breathing's going to be increased, the respiratory rate's going to be increased, and it can lead to respiratory distress. Circulation, you guessed it, they're going to have tachycardia, they're going to have cyanosis, they may complain of chest pain, and they're going to be hypotensive. They're just going to have venous congestion. They can even get a pleural effusion or edema. All right. D stands for disability, and their level of consciousness will be decreased. And then E, that head to toe assessment, one of the things you'll find is cool, pale extremities. Okay? So, how do we confirm that we have a pulmonary thrombosis? Usually a CAT scan with contrast. Yep. They can do an echocardiography or an angiography, but I think a CAT scan with contrast is what they usually go with. The treatment is anticoagulant therapy. I want to let you know, if that's not acting emergent enough, you can go to fibrinolytic therapy for severe cases. Okay? If you're thinking obstructive shock, you picked another one that is obstructive shock. Okay, our next T is cardiac thrombosis, and I have some good news for you. That is very rare in infants and children. Thank God, right? Because it's a blockage of blood flow within the coronary arteries or vessels, basically. And, it can lead to myocardial infarction. We don't want that for our pediatric population. They haven't lived long enough. We need to work on these guys, support their ventilation, support their circulation, BBLS ready. Let's get these guys back, right? But depending on where the blockage is, it can lead to sudden death. That's scary. If you took my ACLS class, you know that their EKG is going to show ST segment elevation, ST segment widening. It can be inverted. Even the Q wave can be distorted. So keep that in mind for your cardiac thrombosis, okay? The next one is toxins, and this is really the last one, but we're going to add one for consideration. But this last one here is toxins, and toxins for children, a little bit scary because, for them, everything's a go. If it's there, it can go in the mouth, and we don't want that. So some of the things they ingest could be dangerous to them. If you have visualized your child ingesting something that they should not have, poison control should be called immediately at 1-800-222-1222. Okay? The hospital will do it as well. You want to get them to emergent care. Now, a lot of you out there, healthcare workers, know if it's an opioid overdose, a benzodiazepine overdose, or ETOH overdose, which is alcohol, Narcan is a good reversing agent. For opioids. For benzodiazepines, Romazicon. I don't have my water here, and I really need it. I wanted to let you know, if you see polymorphic VTAC with torsades on their monitor, consider that they might have ingested a beta blocker, an antidepressant, or a calcium channel blocker. I found that interesting. Okay? So be prepared to support ventilation and circulation on these patients that come in having ingested something toxic. But remember, there are other things that are toxic to their body. Sepsis is something that comes to my mind. Okay, so anything that doesn't make the body happy, it's unhomeostatic. It's a toxin to the body. But I wanted to go over these with you. Um, Frequently toxic toxicity is temporary, but the support for the resuscitation efforts can be lengthened, and that's okay because it gives them a better chance of survival. ECMO is something else that we can tap into to improve their chance of survival. All right, so I wanted to share that with you. Now, look, there's one more T that's not really part of American Heart's mnemonics, but I would like for you to consider it as a T, and that's trauma, right? Trauma is just a consideration, all right? And so the reason is because it can cause pulseless arrest in so many situations, right? So this is where our secondary assessment, the assessment that we do with our caregivers, is so important because we want to get the events leading up to this traumatic event. So whatever the trauma is, we need to get a good, solid secondary assessment from the caregivers. All right? Consider your H's and your T's when you have a trauma patient. That's what they're there for. So consider your H's and T's. All right? Support ventilation, support circulation, be BLS ready. All right? That's Michelle going over the H's and T's with you. I hope you enjoyed it. Be sure to subscribe to my channel. Like my videos. It helps a lot as I'm trying to further this along. And I'll see you in the next video. We're going to discuss some of the scenarios that I've noticed on some of the tests that they're putting out. I want to go over some scenarios with you to try to really help you out a little bit. Okay, so that's coming up next. Michelle signing out. I'll see you later. Have a great day. Bye-bye.